Hello, intrepid learners. Welcome to this review of pain and inflammation pharmacotherapy. I am Dr. Amber Cann. Let's get started. I'll give you a moment to review the learning objectives for this video. Of all the serious and complex medical conditions that we as healthcare professionals have to treat, pain is one of the most frustrating. Pain is an extremely broad and complex bundle of pathophysiologies. Patients that have pain are affected physically, psychologically, socially, spiritually. And it's been very frustrating for us as healthcare professionals to find the right balance to treat all of those layers. Pain has an enormous effect on the U.S. economy, on the global economy. Over 26 million Americans experience pain in any given month, and it's the most common reason for a patient to seek care from a clinician. Before we dive in, I want to recommend a book by Travis Reeder. The book is called In Pain, a bioethicist's personal struggle with opioids. It's an enormously personal and insightful book about a person who was in the healthcare field, had an accident and required opioids because of a trauma, and then had an enormously difficult time coming off of opioids because his clinicians didn't know how to wean him off properly and didn't know how to treat him as a patient with pain. We think of pain as either acute or chronic, and then pain also is either nociceptive or neuropathic. Acute pain, of course, is a recent onset. It has an identifiable cause, and it's transient. It is self-limiting. It goes away once the identifiable cause is treated. Chronic pain, of course, is ongoing. It's recurrent. It lasts beyond the usual acute illness. So even though an injury is treated and has resolved, chronic pain persists. Nociceptive pain is due to an identifiable injury. You cut your finger. The injury is the tissue damage on your finger, and that's nociceptive pain. It subsides once the injury heals. Neuropathic pain is damage to nerves and damage to the central nervous system or the peripheral nerves. It may not be due to an identifiable injury. You may not be able to look at a patient and identify a wound or a cut, but the neuropathic pain is still perceptible through the nervous system in the patient. As clinicians, we've all seen the universal pain assessment tool. We've been taught that pain is a vital sign, right? And this is the tool that we use most often to have patients assess their pain. The book by Travis Reeder goes into detail about how this pain assessment tool is so problematic. We can't point a pain thermometer at a patient and gauge their level of pain. And because of our own experiences in life, two different people may have very different assessments of where their pain is. A few years ago, I broke my leg. And before that, I would have had a very different assessment of what maximum pain is. I have never given childbirth, and so I imagine that childbirth is even more than the pain of having broken my leg. But because of that, my pain assessment over the years has changed. And you can see why this scale is not a perfect scale for how we treat patients with pain. Another problematic facet of this scale is it doesn't cover all of the other factors of pain that we discussed. The psychological toll of pain, the physical limitations of pain, the loss of independence because of pain. So you can see if we boil down something complex like pain to a number scale, we are inherently under-treating the patient. So when we start to treat all of those facets of pain, what are our goals? Well, first we want to address that acute pain aggressively. We want to find the cause, an injury, a wound, and make sure that that cause of the pain is adequately addressed. We'd also like to prevent chronic pain that may occur in the future. We want to treat chronic pain continuously and effectively and improve the patient's ability to function and quality of life. Not all pain is inherently going to be eliminated completely, but most patients will say that they can deal with a certain amount of chronic pain if their disease state is such that it demands that. So if we have a patient who has acute pain, post-op pain, the pain relief that we can shoot for is that allows the patient to attain functional targets, to return to their previous functional status. A patient with chronic non-malignant pain, we have a different target for them. Our pain management goals for those types of patients is to improve and maintain the patient's level of functioning, to decrease the pain perception, but also reduce the amount of medications that they use, improve quality of life. And then for patients with chronic malignant pain, cancer pain, we want to adequately relieve the most amount of pain we can while maintaining the function that they have that allows them for freedom of movement, freedom of choice, and minimizing the adverse effects of those medications. Non-pharmacologic treatment of pain is always considered first-line therapy. Before we reach for a medication, we should always think about, can this pain be managed with something other than a medication? By doing so, that helps us reduce the overall reliance on medications. It reduces the chance that the patient will become dependent on pain medication. And it's surprising how simple interventions can really help reduce patient stress and thereby reduce pain perception. Some of these non-pharm interventions include cognitive behavioral therapy, mindfulness training, training the patient to get better sleep, adding exercise regimens to a daily routine, massage and physical therapy, TENS units, and even hyperbaric oxygen. The WHO has a 3-step analgesic ladder that they have published and is considered a very important guideline to treat patients with pain. For mild pain, they suggest non-opioid agents and adjuvant agents optionally. If a patient can be treated with a non-pharmacologic method, that's even better. But if you need to add a medication for mild pain, a non-opioid agent is what you choose here. Moving up the ladder to moderate to moderately severe pain, the WHO recommends a weak opioid plus a non-opioid, and then adding adjuvants if needed. For patients with severe pain or cancer, malignancy type pain, they recommend a strong opioid plus a non-opioid and any adjuvants that might be necessary. This is another algorithm you might see that could help you choose a pain therapy regimen for a patient. If you move through this flow chart, you will see it will ask you to identify the type of pain and then assess the severity. If the pain is mild, then it's suggesting acetaminophen or a non-steroidal anti-inflammatory agent. For moderate pain, it's suggesting an opioid and acetaminophen plus an NSAID. And then for severe pain, it's suggesting an opioid analgesic and some other recommendations. For all 3 of these options, you'll notice that we're constantly assessing, is the selection that we made adequate to treat the pain? And we should always be monitoring the patient for effectiveness and for safety. When we think about the nervous system, we have the peripheral nervous system and we have the CNS. So at the periphery, we have the nociceptors, say on the tip of the finger, and then those nerve fibers go into the spinal cord, and then the spinal cord carries those. So what we'll talk about first are the non-steroidals, non-opioid anti-inflammatory agents. Those are things that act on the periphery. Acetaminophen, or in Europe they call it paracetamol, it is one of the most common pain relief agents used worldwide. Brand name, of course, is Tylenol. It's available over the counter. It's also available in a IV form, brand name only. It's generally well tolerated, has very few GI side effects, definitely less than NSAIDs, and it's included in a lot of products. In fact, I recommend that patients never use multi-ingredient products because there is definite overlap in a lot of them, and it's very easy to get a toxic dose of acetaminophen really quickly. Patients don't realize that so many cough and cold products and fever reducers and allergy medications also include acetaminophen. Generally, the dose is considered 325 to 650 that's milligrams, every 6 hours as needed, and you never should exceed 3 grams in a 24-hour period. Anything more than that and anything at 3 grams over a longer period of time puts the patient at risk for liver toxicity. And patients with liver disease, liver dysfunction, should avoid acetaminophen altogether. As widespread as its use, acetaminophen is arguably one of the most dangerous over-the-counter products that we have. In fact, an article in the respected medical journal called The Lancet said that if acetaminophen were discovered today, it would never be available without a prescription. You might think because The Lancet and other professionals believe that acetaminophen is so dangerous that the FDA would be working on making acetaminophen labeling and packaging and prescribing more safe. You would be wrong. That quote from The Lancet was from 1975. Non-steroidal anti-inflammatory drugs, or NSAIDs, are another choice for non-opioid over-the-counter relief of pain. They work by reversibly inhibiting both cyclooxygenase 1 and cyclooxygenase 2. These are both enzymes that increase prostaglandin precursors. So by inhibiting COX-1 and COX-2, we are decreasing the formation of those prostaglandin precursors. Thereby, we get an antipyretic, analgesic, and anti-inflammatory effect. NSAIDs are used for mild to moderate pain, and they can be used for fever as well. There are many drugs in this class. Each of them have a slightly different side effect profile and safety profile. And if a patient doesn't respond to one NSAID, it's not necessarily true that they won't respond to another one. So a 1 to 2 week trial is recommended, and then switching to a different NSAID before moving on to an opioid analgesic. NSAIDs as a class have a boxed warning. That's the highest level of warning issued by the FDA. And this warning states there is an increased risk of cardiovascular thrombotic events, including MI and stroke. And it also says they may increase the risk of GI irritation, inflammation, ulceration, bleeding, and perforation. So it's very important to know this about NSAIDs before prescribing to someone who is already at risk for a cardiovascular thrombotic event, or who has an active GI bleed, or is even at risk for a GI bleed. Here's a list of all the NSAIDs that are available either by prescription or over the counter in the U.S. The ones that don't have a brand name listed don't currently have a brand name in production. Some of these are so old that even brand names are not manufactured anymore. I will mention that celecoxib, brand name Celebrex, is the only COX-2 selective agent on the market currently. There have been other COX-2 specific agents on the market, but they were withdrawn because of an increased risk of cardiovascular events with those medications. Celecoxib doesn't seem to be subject to that risk. I'll also mention that the only topical formulation of an NSAID is available in the form of diclofenac. There is a Voltaren gel on the market in the U.S. Many drug interactions occur with NSAIDs, so you need to be informed about what other medications your patient is taking before you prescribe an NSAID. These drugs are metabolized by the CYP2C9 enzyme system and also the CYP2D6 liver enzymes. If a patient is on an ACE inhibitor, they can attenuate the efficacy of NSAIDs by blocking the vasodilator prostaglandins. Warfarin, of course, increases a patient's risk of bleeding, and NSAIDs do this as well. So using these together is not recommended. There's also an increased risk of peptic ulcers when a patient is on glucocorticoids, and adding an NSAID could put the patient even more at risk. This table gives you an idea of the approximate max daily doses of the current NSAIDs that are on the market. It's very rare that a patient would take the max amount of the dose daily for a long period of time, as that would put them at risk for all of the adverse effects that we've mentioned. There is one non-opioid centrally acting analgesic on the market, and that is tramadol. Brand names of that are Ultram, Ultram ER, Ryzolt, and Rybix ODT. ODT stands for orally disintegrating tablet. So tramadol binds to mu-opiate receptors in the CNS, and that causes an inhibition of the ascending pain pathways. It also inhibits reuptake of norepinephrine and serotonin. That's similar to some antidepressants that we know about. Because tramadol binds to these mu-opiate receptors, it's understood that tramadol could be habit forming. Its potential for dependence is very low, but there is the possibility, especially in patients who have had a history of an addiction in the past. When tramadol in the brand name Ultram was first put out on the market, it was not a controlled substance. But as use continued, it was clear that there was an addiction potential, and so states began to apply a schedule to the tramadol that was being prescribed in their states. Now, as of 2014, tramadol is federally controlled. It is now in the Schedule 4. We will now move on to opioid analgesics. Morphine is considered the gold standard, and we measure all other opioids' potency to it. I want to first start off to say that there is appropriate use of opioids and there is inappropriate use. Opioids are indicated for moderate to severe acute and chronic pain. They should never be used when a non-opioid analgesic is indicated. They are considered first-line therapy for certain conditions. Pain associated with procedures like surgery, even dental surgery, pain due to trauma, pain associated with terminal illness like cancer, pain associated with an MI, and visceral pain such as appendicitis. Now we know opioids act centrally on those mu receptors in the brain, but they also have a direct action on smooth muscle in the gut. This is the reason that opioids cause a lot of constipation. In addition to their effect on the gut, opioids also have broader system-wide effects. They can cause bronchoconstriction, they can decrease urination and increase urinary retention, and they can also cause meiosis. That is the constriction of the pupils in the eyes. The one exception to this is the opioid called meperidine, which causes mydriasis, which is the dilation of the pupils. We take advantage of opioids' action on the CNS to reduce pain and to suppress cough, but that action on the CNS also has some downsides in the form of decreased mental alertness, feelings of euphoria or dysphoria, and the most dangerous side effect, respiratory depression. This list will give you an idea of how opioids compare to our gold standard of morphine and to each other. This chart lists the analgesic potential, the antitussive potential, incidence of nausea and vomiting, and their potential for respiratory depression. You can see how they compare to morphine, which is there in the middle, and to each other as far as their relative addiction potential. As you can tell, there are many opioids on the market. Some are short-acting and some are more long-acting. Some dosage forms allow short-acting opioids to be longer-acting. So let's first talk about the immediate-release short-acting opioids. Oxycodone and hydrocodone are both in this category. They are often combined with acetaminophen and less often with ibuprofen in combination dosage forms. They're both equal in their pain controllability, but they're also equal in their abusability. You really should avoid codeine and tramadol for pain relief, especially moderate to severe pain relief, just because there's a wide interpatient variability in metabolism of these two drugs. They don't really provide reliable analgesia, and there's a lot of adverse events associated with these two. Unfortunately, there's no universal recommendation for choice of drug in the short-acting opioid category, and many of your decisions about selecting a drug will be based on patient factors. These things could include age, ethnicity, gender, the hepatic and renal function of the patient. If you have genetic information on how they metabolize drugs, that could definitely influence your drug selection. And whether they have coexisting disease states like respiratory or cerebrovascular disease. Here's a chart that shows the equianalgesic dosing of the opioids that we commonly use. Morphine there is at the top, and it's considered the gold standard that we compare all the other opioids to. So you can see that buprenorphine, just below morphine there, has an equianalgesic dose of 0.3 milligrams when given IV. That would compare to 10 milligrams of morphine. Going down the list, if you just were to select oxycodone, 10 milligrams of oxycodone would be roughly equivalent to 10 milligrams of morphine given parenterally. On the oral dosage side, hydrocodone 30 milligrams would be equivalent to 30 milligrams of morphine. Oxycodone 20 milligrams would be equivalent to morphine 30 milligrams. This is a handy chart to have if you have a patient who needs to switch from one opioid to another. Now let's talk about long-acting opioids. They work in the same way that opioids that are short-acting work. They work on those mu receptors in the CNS. They could be long-acting because of the dosage form or the properties of the drug. More often, it is the dosage form that we're thinking of when we think of long-acting. So adverse events are the same: constipation, nausea, itching, dizziness, amnesia, and mental state changes. Those are all across the board on all opioids. There is a boxed warning related to long-acting opioids that there's an increased risk of misuse and addiction and life-threatening respiratory depression when using long-acting opioids. In the past, especially when OxyContin came out, patients that were prone to abuse of OxyContin found that the tablets were easily crushable. And because they're long-acting, they put a lot more drug in each dose, which is intended to be released over a period of time. So, for instance, an OxyContin 80 milligram tablet would be released, that 80 milligram would be released over 12 hours. Patients who crushed the pills noticed that they could get the entire 80 milligram dose in a very short period of time to their bloodstream. That caused a major high feelings of euphoria, but as you can also imagine, it caused a lot of respiratory depression. This was a major reason for opioid overdose deaths early in our discovery of the long-acting opioid dosage forms. I want to say a word here about how to taper off patients who have been on long-term opioid use. There are several guidelines that are now coming out that suggest that Very, very slow tapers is the safest way to do this. 2 to 5% per month. In the past, physicians have recommended patients just cut their dose by 25% every week, and then they would be off their dose in a month's time. Many patients experienced withdrawal from the medication and an increase in pain because of this taper that was way too fast. Now, a lot of organizations are suggesting 2 to 5% per month. That means that the taper to off is going to take months. Because patients were discovering that these high-dose, long-acting dosage forms were easily abusable when the dosage form was destroyed, the FDA required manufacturers to innovate and create abuse-deterrent formulations. The products that are approved by the FDA on the market currently with this type of technology is listed there. Some of them are Oxecta, Exalgo, OxyContin, Suboxone, Embeda, just to name a few. I will note that OxyContin didn't originally have this technology, but they reformulated as a result of all the problems that they had with the abuse potential of their original formulation. One of the first abuse-deterrent formulations that are used now is called aversion technology. And what that does is it impedes opioid extraction from a dissolved tablet. What patients would do is they would crush an OxyContin tablet or a number of other types of medications, even non-extended release dosage forms. They would crush those, dissolve the powder into water or alcohol, withdraw that solution into a syringe and inject it directly into a vein for an immediate dose. This aversion technology prevents the opioid from being extracted from that solution. And so it causes the tablet to form a viscous gel, and that gel traps the opioid contained inside. Another type of physical barrier that's possible in a dosage form is called Osmotic Extended Release Oral Delivery System, or OROS, O-R-O-S. This technology uses an osmotically active bilayer core. It encloses a semi-permeable tablet shell membrane, and that allows the consistent delivery of over a 24-hour period, and it's also a physical barrier to the abuse potential. A third method that we now use for abuse deterrent is intact. That's a tamper-resistant technology designed to prevent modification of the drug into a fine powder, so it prevents the tablet from being crushed. And it also provides resistance to dissolution of a powder into liquids. So if any of the tablet were to get crushed enough to be into a powder, if it were dissolved, it would create a viscous gel and therefore would not be able to be injected into a vein. So here's one example of that abuse-deterrent technology used in Embeda. That's a medication that has morphine sulfate in it. That's the pain relief part. And then it has naltrexone, which is a opioid antagonist. Embeda has a fixed dose combination of morphine and this naltrexone in it. And when swallowed, the morphine is absorbed. But if it's crushed, the naltrexone is also absorbed too. So it prevents the action of the morphine unless it is in an intact dosage form. If you recall the WHO pain ladder, they recommended adjuvants at every point of the pain ladder scale. And if you can control pain with a lower level of that ladder with an adjuvant, that is certainly more preferred than moving on to an opioid. The first adjuvant therapy that have been used for a long time are the Tricyclic antidepressants, or TCAs. These increase synaptic concentrations of serotonin and sometimes norepinephrine in the central nervous system, and they inhibit reuptake of those neurotransmitters. They are indicated for adjuvant pain for either chronic or neuropathic pain. Tricyclics have been used for neuropathic pain for many years and have been proven very effective. They come in a PO dosage form. They tend to be very anticholinergic, That means that the patient could experience constipation, nausea, dry mouth, worsening of glaucoma, worsening of urinary retention, and they do cause a lot of drowsiness. There's also a boxed warning as a class on TCAs because they have an increased risk compared with placebo of suicidal thinking and behavior. That's actually a boxed warning on all antidepressants. Some TCAs have a cardiac component, and so in their adverse effects, so they do recommend that an EKG be performed prior to starting a TCA. You should not give TCAs to any patient who has atrial fibrillation or heart failure. Agents in this class include amitriptyline, nortriptyline, desipramine, and doxepin. Another class of antidepressants that have been used for pain control or pain adjuvant are the SSRIs, the selective serotonin reuptake inhibitors. They also prohibit the serotonin and norepinephrine uptake in the synaptic gap. They're used for chronic and neuropathic pain. They're all PO, and they do cause some constipation, dry mouth, and dizziness, drowsiness, but not near to the extent that the TCAs do. As an antidepressant class, they do have the box warning related to suicidal thinking and behavior, so you do want to monitor your patients. You shouldn't give them to patients who have AFib or heart failure. However, in this class, there are two agents of particular note for pain control. Duloxetine, brand name Cymbalta, is approved for neuropathic and musculoskeletal pain. It's the only SSRI that has an FDA-approved indication for this type of musculoskeletal pain in particular. Milnacipran or Savella is approved for fibromyalgia, which we know is a neuropathic type pain. These both have approved, FDA-approved indications for that type of pain. Another class of drugs that have been used for neuropathic and chronic pain are the anticonvulsants. Anticonvulsants come in a lot of different varieties and they work in many different ways. This chart has a list of just some of the medications that have been used out of this class to treat various types of pain. There are also topical analgesics that we haven't mentioned yet. We mentioned that diclofenac in the NSAID category has a topical dosage form, but there's also lidocaine and capsaicin. Lidocaine or lidoderm has a dosage form that comes in patches, transdermal patches. They're very well tolerated, indicated for post-herpetic neuralgia, but could be used for any number of neuropathic type pains. And they're applied for up to 12 hours in a 24-hour period. The patient can apply several different patches, up to 3 different patches at one time. Capsaicin is a product that's available over the counter. It has the active ingredient that is in hot peppers. So the patient applies this 3 or 4 times a day. The key thing to remember is that the patient has to apply this for 2 to 4 weeks of continuous use before they see much of a benefit. It produces a heat sensation when applied to the skin, and it usually lessens after about 3 days. But we do recommend that the patient don't touch their eyes or mucous membranes after applying, and then washing their hands if it's not their hands that they're applying it to. Both of these products act locally, so they can be used with other systemic medications to work together to reduce pain. One last category that many clinicians fail to recognize as a valid pain control strategy is the use of medical cannabis. Patients are using CBD because it is now readily available in many retail outlets, and you may get questions about its role in pain management. So first, let's distinguish the difference between THC and CBD. THC is the psychoactive component of cannabis or marijuana. It's the one that causes a euphoric feeling and sometimes paranoia, delusions, and appetite stimulation. On the other hand, CBD has a lot of receptors throughout the body They appear on many, many different tissues, and it seems to have a role in the regulation of inflammatory processes. CBD has a vast potential that we're just now realizing in the role of pain control and anti-inflammatory effects. So patients should be asked about their use of cannabis when you're talking to a patient about their full pain management strategy. If you do not ask patients about cannabis use, it is likely they may be finding use for cannabis products and they're not going to tell you about it. The risk here is that there are many, many drug interactions of cannabis products with prescription and over-the-counter medications. So we need, as clinicians, to be more proactive in asking patients about cannabis use, both recreational and medical, and trying to fit this part of medical therapy in with the so-called traditional approaches to pain management. Thank you so much for joining me for this review of the pharmacologic management of pain and inflammation. I am Dr. Amber Cann.